Well, hi, everybody. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar, which is hosted by Health Data Analytics Institute. And it is entitled Exclusive First Look at the 2023 ACO Performers. So you're going to get some behind the scenes info and very exciting to hear what we're going to hear today. So I'm glad you all joined us. A few items of note before we get started. Everyone has joined today in listen-only mode. This is a traditional webinar format, so you don't need to worry about muting your microphone or turning off your camera or anything like that. All that's been done for you. Also, the session is being recorded. And so what's going to happen is when we're done, you're going to receive an email from one of us, maybe about an hour or so after the conclusion, and it'll have a link to where you can rewatch the webinar itself and or share it with colleagues, and we hope that you do. Also a place where you can download the slides, and I'll say this again towards the end, but it should be a lot of opportunity for you to have access to that ongoing. And again, we hope that you do share that with colleagues and friends. Finally, we'd love to hear from you during the session today. So we are going to have a time for some Q&A towards the end. So if at any time during the session you have a question, go ahead and ask that using your control module. There's actually a specific space. So drop your question in there. We're going to get to as many as we can. If for some reason we don't get to yours or aren't able to or run out of time, don't worry. Someone will get to you through email afterwards, and we'll make sure we answer your question. So without further ado, I want to introduce our speaker today. It's Mr. Josh Gray, and he is the VP of Analytics Services with HDAI. And you're also going to meet during the Q&A Ms. Carola Endicott, and she's the VP of Marketing and Customer Engagement. She's going to help us handle some of the questions that come through. So I'm going to turn it over to you at this time. Josh, welcome.
Thank you very much, Garrett, and thank you to everyone that is joining us. I guess it's a good afternoon for those on the East Coast in the center of the country, and good morning for people towards the West. As Garrett said, I oversee analytics services for Health Data Analytics Institute, or HDAI. And for those of you not familiar with the company, we're a predictive analytics and care optimization company. We work with several dozen ACOs and a number of large health systems around the country. And we have a platform called Health Vision. Health Vision helps ACOs identify and proactively manage high-risk patients. It equips them to know exactly what's going on with the patient, what their medical history is, and what their risk profile is before a care manager calls them. And we also rely heavily on a variety of artificial intelligence techniques to sift through patients' records and give clinicians and care managers exactly the view they need depending on what point in the care process they find themselves in. And as Garrett said, I'm joined by Carola Endicott, who oversees customer engagement for HDAI. One of the things about HDAI is that we are one of a small number of companies that has access to all Medicare fee-for-service claims through CMS's Virtual Research Data Center, or VRDC. We have access to claims going back more than 20 years, but also as currently as last month. And that's really what lets us give you this early read that we'll be covering this afternoon. My colleagues and I have been working around the clock for the last few weeks to sift through this data to isolate some insights. So we're very happy to share this with you. We could use any feedback and direction you could offer, but this is the first time we are showing this to anyone, really. So, Carola, could we go ahead to the next slide? So the things that I'd like to cover in specific first are how you're doing. How are ACOs performing in 2023? What are the best performing ACO types? We have found very different performance patterns depending on whether an ACO is independent, if they're affiliated with a health system, if they're for profit, if they're not for profit, and so forth. And we'll be looking at how cost effective they are and at how proficient they are in documenting care. I also have a segment called What Makes Great ACOs Great. And so to the extent that time allows, we'll be diving a little bit deeper to look at a profile to really try to isolate what the best ACOs do differerly relative to average ACOs. And then finally, we have sort of an honor roll, I guess, of specifically the ACOs of the 579, I think, that we looked at that are turning in the best performance overall amongst all ACOs and for specific segments. Before we get too deep, just one administrative note, because I really hope that this is the beginning of a dialogue with at least some of the organizations that are here today. If at any point, as we go through these materials and later as we respond to your questions, you're curious about how some of the numbers that I'll be reviewing applies to your own ACO, we have generated all of this data for every MSSP and REACH ACO in the country. We have packaged that into very, kind of a very brief but hopefully informative benchmarking report. And if you're curious to see your ACO's performance, just type in report in the dialog bar or send Carola or I an email, reach out to us on LinkedIn, whatever works for you. We'd love to share the general information I'll be sharing on a specific basis with anyone that is interested. And with that as prelude, let's push on a little bit more to the next slide, please, Carola. So I'll really be focusing on two metrics this afternoon. I'll be showing more than that, but the two most important metrics are what we call the savings rate and RAF documentation capture. And we're focusing on these two metrics because we really think these are the two most important metrics in driving the overall financial and business performance of ACOs. And without that strong financial baseline, it'll be more difficult for you to have the resources to invest in expanded care management infrastructures, which allow you to really deliver on the promise of accountable care and population health. So again, the savings rate and RAF capture rate are what we're going to be focusing on the most. And because they're so important, I'd just like to spend a minute or two being as specific as I can in terms of what we mean by both of those metrics. So let's start with the HDAI savings rate. What that does is it quantifies how much how effectively specific ACOs manage the cost of care for the patients that they serve compared to all Medicare fee-for-service patients. And the way that we do that is for every Medicare beneficiary that's attributed to your ACO, we find their digital twins, and we do that by sifting through a very large quantity of data for each of the 30 million or so Medicare fee-for-service beneficiaries. And for each individual, we match them to the individuals that are their age, their gender, their ethnicity, match their enrollment status, and most importantly, match their medical history in very acute and specific detail. And so when we compare the cost of care for the patients that you're serving, we compare it to the actual cost of the digital twins of each of the patients that are attributed to you. This is a bottom-up analysis. We think it is better. We think it's more rigorous than each of the kind of top-down analyses that we've seen. We've spent years developing it, and we've actually validated the results of our modeling exhaustively and published the methodology in a few different leading medical journals. So if you're interested, again, just send us a note and we can send you that work. Next page, the other metric that we'll be looking at. Carola, if you could go on to the next page, please. is what we call the RAF capture index. And I'm sure all, or at least most of you, are familiar with RAF. It's a risk adjustment factor. It's used by CMS as one of the key inputs in determining your benchmark and the acuity of the population that you serve. The higher the RAF, the better your revenue stream will be. But RAF scores depend on documentation, and busy physicians are often not in the best position to be able to document care effectively, nor are the staffs that surround them. And so, what we do in the RAF Capture Index is, again, we take each of your patients, we match them with patients with the same RAF at the end of a calendar year, and with similar medical histories, and then we compare the extent to which your RAF score, the RAF score of a specific ACO, increases quarter by quarter compared to those twins that you have. And again, it's bottom up. It implies a rigorous twinning methodology, and it gives us at least a sense of how thoroughly you give an ACO documents the type of care that will filter into the RAF score. And so a positive value means that you're documenting care more thoroughly. A score less than 1 will indicate that your other ACOs are documenting care for similar patients a bit more completely, which translates into a higher RAF score. So I'm sorry to kind of belabor those benchmarks, but I wanted to try to be clear in terms of the data that we'll be covering moving forward. So let's go ahead, Carola. And in terms of the actual data that we want to share with you, the first is, I think, reasonably reassuring news, which is that 2023, we think for most ACOs, is turning out to be a decent year. When we look, and this is just MSSP, we'll expand the analysis to include REACH programs shortly, but when we look at ACO performance for MSSP organizations, year to date, we believe that about 61% of ACOs will come in under their CMS benchmark. That's just slightly under the average for 2020 to 2022. The savings rate that I described, we believe will come in at 1.7%, and that is slightly lower. In other words, the savings are slightly less than the average for 2020 to 2022. I should say here that the data that we're relying on is derived from claims. Claims are subject to a lag. And so the data that we're sharing with you are from January through September, because again, we get all these claims with a 1-month delay, and we make a few calculations to compensate for claims lag. So the final year numbers may be very slightly different. So it seems like a decent year from the top, but as you drive in, and I shared that savings overall for 2023 were 1.7%, but we're actually on a troubling trend line in that if you go back to 2019, ACOs were saving about 2.5% relative to Medicare fee-for-service as a whole, and that has dropped in proportional terms again by about a third for 2023. And so, it's unclear whether ACOs are becoming less effective, or perhaps that the same cost-effective, I think more likely is that the same cost-effective practices that providers are learning by being associated with ACOs are translating into their same behaviors for non-fee-for-service patients. In other words, part of the value of the ACO program is a beneficial spillover effect. So it's leading indirectly to cost savings, I believe, outside of the ACO population. But in terms of the inherent cost savings of the model itself, still saving money, a little bit less than 2% when you adjust for the case mix issues we've been discussing, but it is going down a bit. So let's push ahead, Carola. These are just overall numbers, and overall numbers really mask a ton of variation across individual ACOs. So what we're looking here is the HDAI savings rate, again, how effective ACOs are in lowering the overall cost of care, adjusted for case mix. and we're arraying that into 5 deciles, and then five quintiles, and then the top 10% on the right. And so the top 20% of programs, for example, are saving about 9.5% of the cost of care, which is really incredible performance in my view. That's about 120 programs or so that are performing at that level. The top 10% of programs are saving closer to 12%. The bottom quintile of ACOs are actually more costly than fee for service. And so it's not only the incentives around ACOs, but it's the extent to which specific organizations execute on those incentives, try to provide high quality care, and eliminate unnecessary expense from the system. Let's go ahead to the next slide, please, Carola. And some of you might be wondering, well, look, we don't get paid based on an actual to expected medical expense ratio. We get paid relative to how we perform compared to a benchmark. And so we took the time to correlate our savings rate quintile against how much and how likely it is that ACOs get paid. Again, if you look at the top quintile here, which is the top line in this table, the HDAI, sorry, I should have mentioned that this is just two-sided ACOs for 2022. So we wanted to eliminate whatever bias might have occurred as a result of different model types. So for these two-sided ACOs, the top quintile in 2022 had a savings rate of just under 9%. 98% of those ACOs came in under their benchmark. 96% received a payout, and the average payout per beneficiary was $689. If you compare that, say, to the third quintile, which saved much less, about 2.4%, three-quarters of them did receive a payout. The payout was a lot smaller than those of the top quintile. So I think for me, the take-home message is that if you're paying attention to the underlying economics of ACOs, that will result over time in higher payment rates. There's a lot that goes into establishing a benchmark. You have, partial but not exclusive control over that. So we think you should also pay attention to your savings rate, which is accessible a lot quicker and we think is a lot more actionable than just having an overall benchmark rate. So let's go ahead, Carola. And in the same way that there's a ton of variation around the savings rate, there is a similar extent of variation around RAF capture. So this is the RAF capture index that I described earlier. This is looking at year-to-date 2023 for all MSSP and REACH programs. The top 10% of ACOs are documenting care pretty meticulously. So 8.6% above what you'd expect on average, given a similar case mix. The bottom and second to bottom quintiles are much lower at -2.2 and 0.4% respectively. And again, this really drives your revenue line to a certain extent. So it's good to know what your RAF practice is and to make sure you're documenting care very not missing health conditions that would filter into your RAF score. Let's put it that way. Let's go ahead to page 11. And so I'd like to spend some time reading out to you how different segments are performing. We'll look at MSSP versus REACH. Not actually, that should say FP for profit versus not for profit. Sorry for that typo. We'll correct it. Versus now there's a large company, Aledade, which is a public benefit corporation, which is somewhere between a for-profit and not-for-profit company, to my understanding. We'll be looking at health system versus physician network. Within health systems, there are really interesting differences between academic medical centers and community health systems. And over the last, 5 or 6 years, there have been a number of very interesting companies that have entered the segment. Lack of a better word, I call them enablers, and we'll be looking at the performance of ACOs that partner with those enablers versus those that don't. I don't have material on here, but before we get into the results, I just want to try to articulate a huge caveat here, which is it's not that easy to categorize ACOs into each of these segments. You might have an ACO that is kind of affiliated on paper with a health system, but really functions independently. The documentation on how an ACO is structured is not always as accessible as is ideal. And so there's a lot of judgment going into these categorizations. And as I share with you, kind of the specific rankings, if there are any institutions that you think would be better characterized in another area, please let us know. We're eager to refine this analysis. Caveat over, let's go ahead to the actual results. And we'll start with MSSP versus REACH. REACH programs give strong incentives to top performing programs. So it's perhaps not entirely unexpected that they're turning in significantly better performance than our MSSP programs. So the average savings rate for each of the REACH programs that we looked at, we think there's more than 100 now, is about 4.8%. That's way larger than the 1.7% for MSSP. And REACH programs have a higher RAF capture index as well, 3.1% relative to 1.1% for MSSP. So there is kind of strong and compelling numbers that suggest that REACH programs are at a higher performance level, and later on in the presentation, we'll share the top 10 REACH programs as numbered by savings rate to indicate their cost effectiveness. Similarly, on the next page, we'll look at kind of for-profit versus not-for-profit status. Again, there's three categories: for-profits, not-for-profits, and public benefit corporations. Again, I had to use some judgment here. So, for example, physician networks that have raised investor money, I put in for-profits. But again, there's a lot of art that goes into classifying at least some of the edge case ACOs. So all of these segments save money. The not-for-profits save the least at 1.3%. Their RAF capture index is only a little bit better than average at 1.1%. The for-profits as a whole are both saving more and documenting more thoroughly. Perhaps not surprising because they have more of a business, likely to have more of a business focus. On average, they save 3.2%. RAF capture is a bit higher at 1.9%. And then, as I said, the one company, Aledade, that I know as being a public benefit corporation, is turning in impressive performance overall for each of the, at least as far as we're aware, 42 ACOs they were partnering with in 2023. If there's someone from Aledade that wants to engage in this further, we'd be happy to talk to you. But their savings rate, again, is 3.2%. Significantly higher than the not-for-profits, and their documentation is better than both not-for-profits as well as non-public benefit corporation for-profits. So depending on what segment you fall in, you may want to look at how your performance both compares to other ACOs in your segment, but also into some of these other segments. So let's go ahead and now look at whether ACOs are affiliated with health systems or physician networks. It's cut pretty evenly, so about 6 million people in health system ACOs, 5.3 million in physician networks. And I think this is consistent with research that I've seen going back some time. The physician networks that are independent, that are not owned by or closely affiliated with a health system, are performing better. They're saving about twice as much. Their savings rate is about 3.1% compared to 1.4% for health system affiliated ACOs. And they're documenting about twice as well as in addition. So physician networks have a RAF capture index of 2.0 versus 1.1 for health system-led ACOs, which I think matches the conventional wisdom. And again, if you'd like us to benchmark your performance, we will show how you rank relative to whichever category you're in, other physician networks, other health system affiliated ACOs, as well as ACOs as a whole. Again, just type report in the comment bar and we'd be happy to get that information to you. I am really, really interested in, within the segment of health systems, how academic medical centers compare to non-academic medical centers. Academic medical centers are, there's not as many of them. There's about 37 or so that we think have their own ACOs, much larger number of non-academic health system affiliated ACOs. And I wasn't sure how this would come out, to be honest, because AMCs have very, very broad agendas, and I didn't know how well they could focus. They're actually pretty comparable to other health system ACOs, again, weaker than physician affiliated, but their savings rate is about 1.2% compared to non-AMCs, which is just a little bit higher at 1.4%. I really didn't expect their documentation to be better, but their documentation is better at about 1.6% compared to less than 1% for non-AMCs. And again, we'll give you top ranking ACOs in each of these categories in a few minutes. So let's go ahead. And then the last category I wanted to talk about was this very interesting segment of the market, which are ACOs that started out independent and eventually partnered with what I call one of the enabling companies. So this ranges from Agilon Health to Pearl Health, Vitalize, Privia, as we've said, Aledade, Caravan. I don't think that this list is comprehensive because I think I may have skipped some MSO, medical services organization type companies, which may qualify as enablers. So if anyone is in the space and wants to engage on this, I would love that. But let's look at these enabling companies for a moment on the next page. Carol, if you could, thank you. And, you know, ACOs working with enablers are doing a bit better. So their savings rate is 2.5% compared with ACOs not working with enablers. They're definitely capturing care better, so 1.8% versus 1.4%. So the enablers, you know, seem to be adding an advantage, but when you mild to moderate advantage. But when you look on the next page, and here we have taken each of the enablement companies that we showed you on the previous page. We've hidden them because we wanted to be, you know, sensitive to confidentiality. But you can see across the enablers, their saving rate varies from 6.6%, which is a pretty incredible number, to enabler G, which is actually not cost effective, saving 1%. And again, the RAF documentation index also varies just as much. So from a low of negative 0.2% for enablement company F, which is not documenting any better than a typical fee-for-service patient, all the way up to 7% for company E, which has been apparently very systematic and focused on RAF-oriented documentation. So let's go ahead now, and that pretty much sums it up for the segment-specific analysis. Again, we'll be making these slides available to you, but if you have any guidance or comments on that, I would be all ears, and I would love to speak with you. But the next, I think, super interesting question is, what exactly makes great ACOs great, and what are they great at? So to do that, I wanted to introduce you to a framework that we have on the next page, which takes each of the segments that you, each of the attributed individuals that you care for, and places them into segments based on their clinical needs, their management needs, and how expensive it is to care for them. So the low risk segment is the 50% or so, it's a little bit less than 50% of patients that really don't have much in the way of chronic diseases and haven't been hospitalized recently. Remember, Medicare 65 and older, there are a lot of very healthy 65 to 75-year-olds. And so these individuals are 50% of patients. They drive 16% of costs. Their PMPM's about a little bit more than $300. Next category is rising risk patients, so similar to the low risk patients, but they do have evidence through their claims history of one or more chronic diseases, haven't been to the hospital in the last year. So those two together are 3/4 of beneficiaries, about a third of costs. We'll be benchmarking, we have benchmarked each ACO against how they do in each of these segments. And so moving to the right, we have the more acute segments, complex care, advanced illness, and individuals in hospice. You can see that the 6% of people, for example, in advanced illness, they account for 25%, a quarter of costs. Their PMPM is $3,800. So that gets pretty close to $50,000 per individual per year. So that is one way that we are looking at performance. And on the and it's part of Health Vision, by the way. It's the sort of information that we share with our clients. But this graph actually was not something I necessarily would have predicted. So the green bars reflect average ACO performance. The purple bars reflect top ACO, top decile ACO performance. And I thought that the top decile ACOs might spend as much or more on primary care and care for low risk patients as lower performing ACOs, but they don't. High risk top decile ACOs save about 9%. You can see on the left for low risk beneficiaries, about 5.5%. That it's more than average ACOs, not a ton more, so 9% versus 5.5%. But it doesn't really necessarily provide support to a going in hypothesis that I had, is that top ACOs are great because they invest a lot more in primary care. We did not see evidence of that. The gap is smaller, but they really save money on the chronic care in advanced illness patients. For advanced illness, for example, you can see the top decile ACOs save about 11%, only 1% for average ACOs. So I think for me, the take-home message is, if you look, you really kind of disaggregate where savings are coming from. Most of the saved dollars are in advanced illness and chronic care patients. So on page 22, we cut it a little bit differently, and it's not patient segment, it's more cost component. This did kind of fulfill what's consistent with my going in hypothesis, which indicates that the top ACOs are in the top level of performance because they manage facilities costs more effectively. So they have 12% lower inpatient costs, 12% lower outpatient costs, as you can see in the two purple bars to the left. They deliver incredible savings for skilled nursing facilities. They save about 26% compared to 10% for all ACOs. Then they actually spend more on hospice, which I thought was interesting, about 13% more given the types of patients that they choose. In terms of Part B, they really don't save money. They don't save much money at all. 3% for top decile ACOs, 1.7 for all ACOs, and for drugs they come in about the same. So I think this, hopefully is instructive in terms of how large the savings are, but it does support the industry knowledge, the industry wisdom that ACOs deliver on their potential by keeping patients out of the hospital, keeping patients out of SNFs, keeping patients from needing high-cost outpatient procedures. And as you can see here, 3/4 of the savings that ACOs deliver really focus on those three facilities-oriented categories. So let's go on from there, Carola. One of it's not the biggest focus of this research, but the ACOs that we work with are really focused on increasing the rate of Medicare annual wellness visits. So there's a really interesting, I think, tactical question about whether that pays for itself. And I think it does. So, for example, if you look at ACOs that have the greatest number of Medicare annual wellness visits, which are that last category, so AWV quintile number 5 on the bottom, they have see to it that about 72% of their attributed beneficiaries get a Medicare annual wellness visit, at least in the so far in 2023. They save on average 4.5%. Their RAF capture index, and this makes sense if you have a Medicare wellness visit, doctors are less rushed. They have more time to document care more effectively. Their RAF capture index is the highest of all these groups. We also have a quality-oriented adverse event composite. Won't have time to get into that much. You can see some of the metrics that occurs on the bottom. But the ACOs that have the most most wellness visits also reduce the number of controllable adverse events the most. So I think this is, there's some question as to cause and effect, but I think this is compelling, at least relative evidence on the benefits of Medicare annual wellness visits, and the fact that you shouldn't be concerned about the extra cost, because that seems to pay for itself in terms of more savings, better documentation, and fewer adverse events. So let's go ahead, Carola. Okay, so here are the rankings. I'll go through these and either get you home early or have time to answer a few questions at the end. And these rankings, by the way, are all on the savings rates. We were a little bit sensitive and didn't want to, let's say we just didn't want to publish the rankings on the RAF factors, but we will share that with you in your benchmarking reports if you're curious to see that information. And so if you look at the top 20 most cost-effective ACOs, maybe some of you will see yourselves, but for me, I think it's just really interesting that they really span a number of different types of ACO. So some of them serve distinct racial or ethnic communities. You have the Asian American Accountable Care Organization at number 7. Sync Care at number 20 serves a population that is primarily African American and Hispanic. You have both REACH and MSSP programs are both represented here. There's one academic, number 16, which is the University of Wisconsin's ACO. So academics as a whole didn't really deliver the highest level of savings, but it is possible for an AMC to do that. And there are a number of companies that are ACOs that are working with some of the enablers. In particular, some of the ACOs that are partnering with Agilon are doing very well, and there's 2 or 3 of them, I think, that are in the top 20. You also have interesting companies like Village MD, which partners with Walgreens, that had one ACO factor in the top 20. So I'll just let that sit for another couple seconds, but why don't we go ahead to the next category, Carola. And we saw earlier that REACH programs, perhaps because the incentives are more pronounced, turn in better performance in general than MSSP programs. You can see the top 10 MSSP programs on the left. So again, you see Asian American, ACMG Health Systems, TPACO, Coastal Carolina. I'm just randomly going through Somos, which is an enablement company ACO. On the right side, you have some of the REACH programs. So Hudson Heights, United Physicians Associated, Collaborative Care Partners comes up on a lot of these lists. And one of the Agilon programs is a REACH program that came in at number 10. Let's go ahead to page 28 if we could. We did see a big difference, as you'll recall, between programs that have health system affiliations, where they may be larger, they may be more complex, they have less clear-cut incentives, shall we say, but there's still some very strong performance. Again, we see collaborative care, ACO Reach of South Texas, Catholic Medical Partners has an ACO in this category, Optimum New York, IPA, and so forth. Again, I had to use a lot of judgment in categorizing these organizations. So occasionally you'll see in IPA, which seems to be working closely with the health system. You could argue on the categorization for those and probably for some other ones as well. Again, the independent ones that are not affiliated with health systems are on the right. Let's go ahead to slide 29. And here you have the top non-academics on the right. So you've seen some of these already. Best IPA, Richmond Quality, Optimum of New York, I think Catholic Medical Partners, I think we've seen those. On the left are the the most cost-effective academic programs that we've come across, the University of Wisconsin, Boston Medical here close to our offices, university hospitals, I believe in Cleveland, Memorial Hermann in Texas, UT of San Antonio and so forth, Stony Brook ACO, Duke Connected Care, and BJC in St. Louis. So another kind of, I think, important lens through which to view ACO performance. And then on the next page, and I think this may be the last ranking that we have, but the enablement companies, the ACOs that are working closely with enablement companies. So we saw a few Agilon companies. You have Best IPA, which is working with Somos, Physician Leaders Direct Contracting, which is working with Vitalize, and so forth. You can just kind of skim through some of these. North Carolina, I think it's North Carolina and Tennessee, MSSP ACO on the bottom is working with Aledade. If you don't see yourselves on the list, I should also caveat that some of these performance levels are pretty close together. And so it could be that number 10 on one of these lists has a savings rate of 11.1% and number 12 has 11.2%. There's, we had to have an arbitrary cutoff, but sometimes when you improve a little bit, you improve to a significant extent in the rankings. I think let's go ahead, Carola, to the next page. Oh, sorry, there's one other ranking I forgot about, which is we've also done rankings for each of the segments that I described before. Some ACOs are cost effective across each of the segments, or at least most of them. So you see Collaborative Care Partners, which has very low or very high savings rate for both complex care and advanced illness patients. Richmond Quality, very strong on advanced illness, and I'm not sure I even see them on complex care. And you can skim through some of these. So again, the benchmarking report will let you know where you stand and where you rank on each of these segments. And let's go ahead if we could, Carola. So I wrote this slide, I think 2 days ago, and the reason we looked at it, a couple of my research partners and I, was that up until this point, we've really been talking mostly about ACO economics, and I was a little bit curious and even a little bit nervous about what the quality would look like. And so on the top, we have arrayed all of the ACOs, MSSP and REACH together for 2023. We have, you can see the savings rates at 11% for the top quintile, 2.6% for the average ACO, negative 1.8% for the bottom quintile. And I wanted to correlate that with the adverse event rate. And this is, how often you see things like kidney injuries, and you can see the list at the bottom, CHF exacerbation, ED visits, unplanned admissions, and so forth. And you can see that the top ACOs from a cost effectiveness perspective are actually the highest quality. And I know that because they have the lowest adverse event rate. Um, Compare that to average ACOs, which still have a slightly lower adverse events rates. The bottom ACOs don't. And so, and this makes sense because to make the finances of an ACO work, you have to keep people out of the hospital. To do that, you have to be proactive about your care. As you're being proactive about care, you are going to see fewer adverse events. And we really wanted to focus on these adverse events because I think most of you are used to seeing some of the quality metrics that CMS provides you with or requires from you in terms of obligatory reporting. We Those are important, valid, of course, but we wanted to show you some other indications that we think are very rigorous, and we have we work hard to derive these rates from individuals' claims history. And I think that might be it in terms of slides. If we could go one more slide, Carola. So this just gives you, I've been mentioning this complementary benchmarking report several times. This gives you a better idea about what's in it. So we'll give you your savings rate uh, overall and by cost components, so inpatient, outpatient, Part B, drugs, cost by segment. So do you have a better savings profile for advanced illness than low risk, for example? This can give you valuable strategic guidance in terms of where you invest your savings. We will also show you your RAF scores and to the extent that there's interest, some of the quality indicators that I just introduced you to. So things like CHF exacerbation, MACEs, major adverse cardiac events, and so forth. And then one thing that I just didn't have room to share with you today was utilization. So annual wellness visits, we did talk a little bit about, but also I'd love to share with you primary care visits, specialist visits, and so forth. And for all of these, we'll be giving your savings rate and your RAF scores. Thank you. That was a lot. Thank you for bearing with us. Again, if you want this, just type in report and we'll get it to you in the comments. It should be a light lift for you. I think we have 12 minutes. If you do have questions, happy to field them. If you need to get on with your days, I certainly understand. I really appreciate you, all of you hanging in there with us and for coming to the webinar. Thank you.
Thank you, Josh. Appreciate it. So I'm going to join you for a sec here and go through some of the questions and comments that we have in this comment section here. And thank you for all the thumbs up. Love it, love it, love it. Keep the thumbs up coming. Just a quick reminder before you leave, if you do want the report, just you can throw it in the questions, or you can certainly reach out to us or through the VBC exhibit hall. They know how to find us. We would be thrilled to work with any of you on this and give you a sense of your results. So Josh, a couple of things. First of all, very simple question. Is it being recorded? Yes, it is being recorded. We'll get that out of the way real quickly, and we'll be sending Garrett and his team will be sending that out after the webinar. We've gotten a bunch of people asking for reports, so thanks for putting those in the comment section, in the question section. So the next question is someone just, I think, joined maybe late, and I think there are probably others who did join late. Just a reminder about where the 2023 data came from, Josh.
Sure. So Health Data Analytics Institute is one of a number of for-profit companies that has gone through an application process and been approved to access the Virtual Research Data Center. The Virtual Research Data Center, for a healthcare nerd like me and my colleagues, is an incredible resource. It includes every claim delivered to every Medicare patient going back to 1999. And so that really gives you a 360-degree view of care because Medicare pays for almost everything. We don't have some Part D drugs for everybody. but we have all Medicare fee-for-service. We have Medicare Advantage, although that's a bit delayed. And that's where we compile our data. So we have access to that every month. So we'll be getting our data through November very shortly. We have to worry a lot about claims lag, but that is how we assign patients into their categories. That's how we infer quality, and that's how we know cost and we know utilization. So the Virtual Research Data Center, CMS asset, incredible resource for measuring healthcare effectiveness of different types of organizations.
Thank you, Josh. All right, following on from that, we had a couple of questions trying to sort of understand how we view cost effectiveness and how it's related or not related to the benchmark that
Yep.
ACOs, kind of live and die by. So thoughts on
Yep.
that?
Yeah. So I'm not an expert on the HHS benchmark. They have a methodology. It is based in part, the anchor year goes back a number of years, and so forth. But to complement that, we really wanted a tool to provide to ACOs to give them very current, very deep knowledge of where they are from a cost effectiveness point of view. So I can tell you your savings rate for Q3 really of this year. It'll be refined over time as more claims come in, but we think we can give you a very accurate read on your Q3 performance, and that is faster than I think you'll get from CMS and how you did relative to the benchmark. As we saw earlier, the ACOs that do better on the HDAI savings rate earn more money. More of them come in under the benchmark, and they come in lower than the benchmark. It also gives us not, in addition to saying, hey, you're doing great or you're running high cost, we have hopefully a rich response to the question of what am I doing right and what am I doing wrong. So you might be managing specialist visits really well, but you might be spending a lot more or saving less on skilled nursing facility and so forth. You might be referring patients to a skilled nursing facility that has a very high readmission rate back to some of your hospitals. And we can sort of peel back the layer of the onion. And so that is why we've invested in the VRDC and in this methodology. And the methodology, I should say, we have been working on, some people from the company have been working on this for 20 years. We have been working on it very intensively for the last 3 or 4 years. It takes an incredible amount of compute resources. Again, we take every patient that is attributed to your ACO, we match them up, whether it be to 10 or 1,000 people. It depends on how close we can get to their medical history, and we look at the actual costs for those individuals. We literally can't figure out a way to make it more rigorous. We've published on it, happy to share, but we do think it'll give you a very kind of sober and detailed and current view on how cost effectively you're delivering your services. And of course, if you're delivering your services cost effectively, that sets you up to generate resources to invest in more care managers, in outreach, so you're able to deliver more annual wellness visits and so forth.
Thanks, Josh. So there's a really interesting question here that I think we would take a lot longer to answer, but we certainly do have an answer for it. How do successful ACOs care for their complex patients? How does this differ from the care for complex patients that is provided by less successful ACOs?
Thank you for that question. And it does, I do want to acknowledge that this, we only had an hour, so this presentation is, pretty quantitatively oriented. We did not have time to get into the qualitative part, which is once you get to know an ACO, you can see their culture and you can see how they practiced. And so for the complex care patients, I would say that a couple of things come to mind. One is that they manage patients incredibly well between visits, and so they have an idea about who to worry about when they reach out to patients. Um, they reach out with a strategy and for a reason, and their population health managers ideally have a good sense of the patient's history. They know what risks they face. And so rather than spend a 15-minute phone call with 12 minutes spent to figuring out what's going on and 3 minutes on decisions and recommendations, they really have done a lot of the pre-work already. I'd say the other thing that they do that comes to mind is they handle transitions really well, and so they have systems to communicate information from one caregiver to another. So you know that you're really concerned about fall risk for one individual and CHF exacerbation for another. So I think that is an important part as well. I'd say in particular for that segment, I mean, you're going to miss sometimes. You're going to have patients that go to the hospital no matter what you do and that need a skilled nursing facility visit. They have really good networks, so they know which SNFs have higher quality, will be able to manage the patient without sending them back to the hospital unless it's absolutely necessary. They work with very high quality home health agencies. So those are a handful of things. Just that it's not something that we've surveyed, but thinking about the great ACOs that we've worked with, they're proactive. They do their homework on the high needs patients. They pay a lot of attention to their networks, especially their post-acute care networks.
Thank you, Josh.
Carla, I
And
don't know if you've seen anything in addition to that list. I'm just kind of going by my experience, and ACOs really well as well.
I mean, this is one of the areas that we do go through with our ACO partners in detail to break it down by exactly where the opportunity lies by segment, and in this case, complex care patient, but also advanced illness patients in the other segments you showed. And that's where we can really suss out. The other day we were talking to someone and we noticed the DME was extremely high, and she said, "Oh, well, that's an indicator of some fraud that we just found." So there's also sometimes surprising findings that can support other kinds of initiatives. All right, Garrett is back. I think he's here to take us
Yeah,
home.
Garrett runs a tight ship, so when
Yeah,
he
I didn't get to all the
Need to be
questions.
the party pooper.
There were some other great ones, but we do have them all captured here, and we'll be in touch with you with those questions. So Garrett, let me move the slide forward, and I'll hand it back to you. Thank you for having us, by the way.
Oh man, this was great. I really appreciate both of you and Josh. What a fantastic presentation. Thanks for joining us today. And obviously, there's a lot more where this came from. This was only the tip of the iceberg, and so I appreciate you guys narrowing it down as you did and staying within the time frame. If you do have a question that we weren't able to get to, and I know there was a lot of those that came in, go ahead and ask it now. We're going to go and answer as many of these as we can through email afterwards. So go ahead and ask your question as we're wrapping up here. But what I would like to encourage you all to do is head over to bbcexhibithall.com and check out the HDAI or the Health Data Analytics Institute virtual exhibit booth that's there. There's a lot of really great resources there that you can check out. You can read up on them, what they're doing in the space, and kind of really educate yourself on their services. And of course, reach out and contact them through there. And then, of course, if you would like to reach out to them directly, feel free to do so. Carol, if you could go to the last slide here, and you will see their contact information on this slide. And so feel free to reach out. There we go. And if you would like for me to facilitate an introduction, I'm happy to do that as well. If you would like to reach out to me, and I can put you in touch directly with them. But thank you again all so much for joining us today. We know that there's a lot going on right now. Christmas is right around the corner as we're recording this. So I hope that you all have a wonderful rest of your week and a very happy holiday. And we'll probably see you in the new year. So thank you so much for joining us. Have a great one. Bye-bye.
Thanks, everybody. Thank you, Garrett.